Welcome to part 3 of musculoskeletal. This PowerPoint is going to focus on fractures and traction. Fractures are broken bones. Bones can break many different ways and either completely break or incompletely break. A completely fractured bone means the entire bone has a fracture through it. Incomplete fractures only have part of the bone that's fractured. The fracture doesn't go all the way through the bone. A closed or simple fracture is a fracture where the skin has not been broken by the break. An open fracture is where the bone has fractured and bone is now protruding through the skin, or the skin has been damaged down to the fracture. Either way, there is broken bone and the skin is not intact at the fracture site. Interarticular fractures involve a joint like the hip. Pathological fractures occur related to a disease process like a bone tumor or osteoporosis. The disease in the bone causes the fracture to occur. And then we have stress fractures. Stress fractures occur in a lot of athletes who have repetitive stress on the bone, like with running and jumping. When we assess our patients for fractures, usually they have acute, continuous, and severe pain where the fracture is. The muscles surrounding the fracture bone will spasm, causing intense pain and loss of function of the limb. The muscle spasms and fracture can cause a broken bone to be deformed or even shorten the limb depending on the type of break. If we palpate the fracture, we may feel crepitus, which is the crumbling sensation of the bone fragments rubbing against each other. The area of the fracture may become edematous and may develop ecchymosis. This does not always happen, so this should not be a reason to think there is or is not a fracture present. Diagnosing a fracture is based on symptoms and doing an x-ray of the bone. Sometimes the swelling around the fracture can make it hard to see the fracture at first, so it's not uncommon for patients to have a repeat x-ray with their doctor a couple of days later and then have the fracture found then. When the fracture occurs, the bone cells get damaged and start to die. The damage to the soft tissue surrounding the fracture starts the inflammatory process, and the body will signal for fibrin to come and clot and form that clot at the fracture site. This is called a fracture hematoma. This fracture hematoma starts the meshwork for new bone cells to grow and adhere to the fracture site. Osteoblastic activity, which means new bone growing, is stimulated and immature bone is formed at the fracture site. This immature bone is called a callus. Over the next 4 to 6 weeks, or 3 to 6 months for elderly adults, true bone will replace that callus. If there's anything that causes damage to the fracture hematoma or that callus, true bone growth will be delayed. This is why fractures get immobilized with a cast or splint while they're healing. The biggest factors that affect fracture healing are also the factors that cause complications. If the fracture is not immobilized, the fracture hematoma or callus will not heal. Every time the fracture site moves, it starts the inflammatory response all over again, delaying the healing. This can also occur if the patient does not adhere to the activity restrictions while the bone is healing. If the fracture site does not have good enough blood supply, the inflammatory response and the hematoma formation will be delayed, which will then delay the callus formation and delay healing. If there's an infection present, which is a major concern with an open fracture, the infection must be treated if the new bone is to grow properly. If the fracture was related to a tumor like cancer, the bone will not heal properly, and usually the bone takes a long time to heal, if ever, and surgical intervention is usually required. Certain medications will delay bone growth, especially corticosteroids. The older the person, the longer it takes for bone healing, and if the person has any comorbidities such as diabetes, bone healing can be delayed. As far as complications, we can classify fracture complications into early and late. Early complications include shock from the fracture, which is normally seen with trauma like car accidents or fractures that tear arteries causing blood loss. If the person breaks a long bone like their femur or their pelvis, sometimes fat from the bone marrow escapes and goes into the vasculature and gets stuck in organs like the brain, lungs, and kidneys. The person could develop compartment syndrome, which is when the swelling around the fracture site is so much that it actually starts to compress the arteries and tissues, causing tissue death from lack of oxygen. You'll learn more about compartment syndrome in higher blocks. The person is also at risk for blood clots in their veins, called venous thromboembolisms or VTEs, which can migrate to the lungs, which we would call a pulmonary embolism. Delayed complications include delayed bone healing, called union. So if the bones are slow to grow together, we would call that delayed union. If they never grow back together ever, we would call it non-union. The bones can also lose blood supply and bone death may result, called avascular necrosis of the bone. The person can also develop chronic pain at the fracture site, called complex region pain syndrome. When we plan our care for a fracture patient and determine their goals, everything we do revolves around pain control, immobilization, assessing for complications, and promoting bone growth. There are so many ways we can do any of these, and it's going to be very dependent on the type of fracture, its location, and the person with the fracture. The initial or emergency care of a fracture really revolves around getting the fracture immobilized with some sort of immobilization device or splint. When we immobilize a fracture, we need to support and immobilize the joints distal to and proximal to the fracture. A lower arm fracture, for example, requires the wrist to be immobilized. A fracture near the elbow may require the wrist to be immobilized in addition to the elbow. If there's an open fracture, we need to cover the opening with a sterile dressing to prevent contamination. We also do not attempt to reduce or reset the bone at this time. Once the emergency of the fracture is over, we move to medical management. This may occur in the emergency department, in the operating room, or may occur a few days later at an orthopedist's office. This depends on the type and severity of the fracture. The emergency immobilization device will be removed and the fracture will be reduced, which means to restore the fractured fragments and align the bone back to its anatomical alignment and positioning. Not all fractures require reduction. For closed fractures that require reduction, providers can manually, meaning with their hands, manipulate the bone back into place and then use an immobilization device to keep it in place, or they can choose to use a traction device. If the fracture is open, surgery is usually required to reduce the fracture using internal fixation devices to hold the bone in place while it heals. Internal devices are not usually removed from the body after healing. When internal devices are used, it's called an ORIF, open reduction internal fixation. They can also use external fixation devices that would be removed once the healing is completed. The first picture shows the types of internal fixation techniques. The second picture is one type of external fixation device that helps realign the bones as it heals. And the third picture is of pins. Pins are a type of internal and external fixation device that holds the reduced fracture in place while it heals. Once a patient gets their fracture immobilized, it's not the end of the care for that fracture. We must assess the limb to make sure that no complications occur. Before the immobilization device is applied, we need to assess the limb, fracture, and signs and symptoms of condition of the site. This helps us know what the area looked like before the immobilization device so we can assess for complications better once the device has been applied. If the area has any lacerations or abrasions, we need to treat those first before placing the immobilization device. Before and after we immobilize the limb, we must assess the neurovascular status. This involves assessing the 5 P's: pain, pallor, pulselessness, paresthesia, paralysis. We're assessing for pain. We're assessing the pulses on the affected limb. We're assessing the skin color of the affected limb, the feeling of the limb, and if the person can move the limb, which usually means asking them if they can wiggle their fingers or toes. Assessing the 5 P's is the best way for us to monitor for any complications with fractures, and we do this for any musculoskeletal injury or condition. Increases in pain or changes with pain are usually the first indicator that something bad is occurring under that mobilization device. Immobilization devices can cause pressure injuries from the device resting on the skin in a position it shouldn't be. If the immobilization device is placed correctly, this shouldn't happen, but it can still happen even with proper application. Patients will usually complain of pain in one spot when a pressure injury is developing. Treating this is going to require removal of the device, treating the injured skin, and placing a new device. Another complication of immobilizing a limb is disuse syndrome. This occurs when the affected limb muscles atrophy or shrink and cause loss of muscle strength. When we care for a patient with an external fixation device, we still want to assess the 5 Ps of that limb. In addition to that assessment, we also need to assess the skin where the pins enter the skin and go into the bone for any signs of infection, as these are open areas of the skin. We need to do pin cleaning and dressings and educate the patient on how to clean and dress these pins. We can elevate the affected limb to reduce edema and help with pain. And we may need to do some emotional support for our patients regarding the body image changes related to having this device. The nice things about most external fixation devices is they allow the person to become mobile faster, since the bone is very well immobilized and is not going to move at all. This allows people to get back to life and not stuck in bed. Sometimes the fracture requires traction to be used. Traction is using pulling forces to the affected limb. Traction helps reduce muscle spasm and reduces, aligns, and immobilizes the fracture. Traction isn't used as much as it used to with all the advances in surgical techniques, but it's still used in cases when the patient can't get into surgery right away, or they may not be a surgical candidate at the moment in time. Whenever traction is applied, a counterforce must be applied. Frequently, the patient's body weight and positioning in bed supplies that counterforce. Traction must be continuous to reduce and immobilize fractures, so we cannot interrupt or remove the force at all. This includes not removing any weights unless it's prescribed. Traction can be applied to the skin using Velcro, tape, straps, or boots, and that is what's actually pulling on the skin, which is pulling on the limb. We need to make sure that the skin does not tear or have any pressure injuries from this type of traction. Traction can also be applied by inserting pins directly into the bone, and we call this type of traction skeletal traction. When we care for a patient on traction, we have to assess the traction device to make sure the application and maintenance is correct. We also need to assess the 5 Ps, assess the skin for any breakdown and tears, and assess for any infection in the pins if skeletal traction is being used. Since the patient cannot move around on traction, we also have to assess for any signs of blood clots, those VTEs, any pressure injuries, constipation, urinary elimination difficulties, and do range of motion activities with the patient on their unaffected limbs. I do want to mention one type of fracture that's common with older adults and that can cause a lot of complications, and that's hip fractures. When I was a new grad, hip fractures in the older adult would cause so many complications that it was not uncommon for that patient to end up in the ICU and they possibly died from the complications. Now, we're so much better with our surgical techniques that we don't see patients getting that sick after a hip fracture, but the risk is not 0%. First, most patients who have a hip fracture have some sort of comorbidity or concomitant problem, like the fracture was due to a traumatic injury and other fractures, or they have health issues that are present from trauma, or maybe they have diabetes, or they have osteoporosis, or they have a bone tumor. This makes the person at higher risk for complications. Secondly, hip fractures hurt badly. The hip is a major joint in the body attached to the strongest bone and muscle system we have, which is the femur and the quads and the hamstrings. Those muscles spasm very fast and extremely painfully. Hip patients can go into shock from the immense amount of pain. This shock is going to decrease their blood pressure, increase their heart rate, increase their breathing rate, and can even affect their level of consciousness, even if bleeding isn't present. Because of the significant pain, the patients don't want to move at all, which can cause pressure injuries, bowel and bladder elimination difficulties, breathing issues that can cause pneumonia, which we'll talk about later this semester, and significant anxiety and difficulty coping. Depending on the comorbidities, the bone healing may be delayed. Thankfully, now most patients are able to go to surgery right away to have their hip fixed, so we can decrease the risk of some of these just by taking them to the operating room and fixing the fracture. The pain is significantly less after surgery, and the patients can start moving very quickly after surgery. Depending on where the hip was fractured will determine what type of surgical intervention will be needed. If the fracture is located on the femoral side of the hip, close to the head, next, and extracapsular region of the hip, the surgeons can do an ORIF and fix the bone like the picture shown. If the hip fracture involves the femoral part of the hip, sometimes they'll do an ORIF of the hip and then insert a rod into the femur to stabilize the femoral fracture. Sometimes the fracture is too bad to do an ORIF and they will just do a hip replacement surgery. When we care for hip fracture patients, we focus on pain relief, fixing the hip with surgery, care for the surgical wound to prevent infection. We use therapies like PT and OT to get the patient up and moving as quickly as possible to restore normal elimination, prevent pressure injuries, blood clots, and pneumonia. And then we're also going to assess the 5 Ps just like we would with any other fracture. And this is the end of part 3.